good day, Vgem, or to all the Vgem students, no, of CPU. Since of the busy schedule of our COVID schedule in our hospital, we tend to have this recorded lesson, no, for our discussion. So our topic for today is all about ventilator management. No, this encompasses in lieu or together with your simulator. No, so this is just an intro, and later we're going to use your tools or your simulators to coordinate or to apply these principles of ventilator management. So why we need to study ventilator management? Any idea? So as the student of ventilator and gas exchange monitoring, no, so ventilator management is a vital topic for this subject because as respiratory therapists, we tend to manage a ventilator. So we'll have a slide. We will check the slides. So until 6 lang. Ah. So we need to study ventilator management. So as you can see in the picture, so before, way back, this is the iron now. So way back during post World War II, the ventilator is all negative pressures, no. So they tend to use the iron lung. So this is the what we call the mother of all ventilator. Sometimes they call it drinkers ventilator or respirator. So drinkers is the name of the scientists who discovered the ventilator. So it has two names, no. And the history, we have the iron lung and the drinkers respirators. So imagine during 1945, anong meron sa date ng 1945? The significant date of 1945 as to recall in the history for the ventilator. It is been the 1945 is the date of during the post-war World War II. So anong nangyari? So during that dates, the history of ventilator, poliomyelitis, no, is very rampant. So it is a pandemic during that days or during that years, no. So because of this poliomyelitis, there is what we call respiratory muscle paralysis. So they tend that the ventilator was massively produced, no. So imagine how big, how space consuming is the iron lung, no, during that year. So but no choice because it is the ventilator is still on the developing stage, no. Whereas today we have portable ICU touchscreen ventilator. So before, imagine kung ganyang kalaki yung ventilator sa hospital, it will consume more space and a lot of area or floor area in order to place one ventilator. Imagine para siyang like a water tank, no, the dimension itself. So what are the types of invasive ventilation? When we say type of ventilation, it can be classified as invasive and non-invasive. So what are the two types of mechanical ventilation? So we have the type of mechanical ventilation. We have the volume controlled ventilation or the VCV, and we have a pressure controlled ventilation. So from its definition, when we say volume controlled ventilation, or with acronym of VCV, it has preset tidal volume. Now, VT stands for tidal volume. So the tidal volume is consistent or preset or controlled. Whereas in the PCV or pressure control from its definition, the pressure is controlled or the pressure is preset. So add on to this, VCV, the volume controlled ventilation is more um, dedicated or targeted for this mode of ventilation is formed on more on an adult patient, whereas the PCV or the pressure controlled ventilation is more uh, targeted patient is more on pediatrics, no? So the PCV, although PCV also sometimes in advanced mode, it is also used for patient with acute ARDS or patient with a special lung condition called ARDS or ARDS or acute respiratory distress syndrome. So the pressure control ventilation can help in terms of lung compliance, no? So we have studies have shown that the pressure controlled ventilation or the PCV improve gas exchange in cases like ARDS. So why? Because it reduces the cardiovascular side effect and barotrauma, because we as the nature of our pressure controlled ventilation, it's more flex ang delivery of air going into the lungs. Pag gumagamit ka ng pressure control is more flex. Ibig sabihin, it can cause a lesser damage to the lungs compared to your volume control. So, less barotrauma, the MAP pressure, the mean airway pressure, and then it decreases the minute ventilation, especially when it is combined with the inverse IA ratio. So you can modify your IA ratio in this case. So this is more on the advanced mode, no, ang PCV based on the studies. So what is ARDS guidelines? So we have guidelines for the ARDS, no. So ARDS stands for acute respiratory distress syndrome. It's more on an adult case, no. So the ARDS network has developed guidelines and lung for guidelines and lung protective strategies. So to begin to help better ventilate the lungs of patient with ARDS or ARDS. So the following is a summary. The four criteria, or these are the four strategies. So one, target tidal volume of 6 ml per kilograms of ideal body weight based on the ideal weight. So you can consider the tidal volume instead of using 6 to 10, which is in a normal patient lung condition. Here, the guidelines of the ARDS promoting a conservative tidal volume, no? So hindi kailangan ng bigger tidal volume. The guidelines teaches or emphasize that the clinicians or the respiratory therapists and the physician must recommend a conservative ml of tidal volume. So it's based on the 6 mils or 6 milliliters per kilograms, conservative. This is the ARDS strategy. Second, strategy criteria or suggestion of the of the ARDS guideline is maintenance of alveolar or plateau pressure of at least less than 30 or within 30 centimeters of water. This is one reason to avoid barotrauma. So the guidance says that the plateau pressure must be less than 30 centimeters of water. And the third strategy they recommend is the use of relatively high positive end expiratory pressure or PEEP levels up to 24 centimeters of water. So higher PEEP, they recommend higher PEEP, and then later that PEEP will be titrated into a lower PEEP, from higher PEEP to lower. So that's the strategy, and the fourth, permissive hypercapnia. When we say hypercapnia, it's promoting carbon dioxide, with the use of lower tidal volume. That's why conservative yung tidal volume is in 6 ml per kilograms lang. And therefore, the lower peak pressure. So peak inspiratory pressure also to promote less barotrauma. So the carbon dioxide or the CO2 levels may begin to rise. So this is what we call permissive hypercapnia. So you are promoting higher level of carbon dioxide. So the condition is only temporary because it's called permissive hypercapnia. In order to elevate the CO2 levels and begin to rise, so resulting in a respiratory acidosis. So the higher the carbon dioxide, so it is promoting more carbon dioxide into the lungs because the main stimulus for initiation of breath of your pneumotaxic and apneustic center is the brain sensing the PCO2 level, no, in order to initiate breathing. So main sensors, no, na or the stimulus that the brain is stimulated is the PCO2 level. So that's why we're promoting permissive hypercapnia. So oxygen targeted the PO2 of 55 to 80, and then the SPO2 of 88 to 95%. This is the continuity of the ARDS guidelines or strategy should be assessed every 4 hours. So there will be an assessment every 4 hours upon hooking of your hemodynamics or your blood class. So the targeted pH of according to the guidelines must be 7.30 to 7.45. And the other guidelines, avoidance of excessive high FiO2 level to avoid oxygen toxicity. So the guidance says that the FiO2 must be maintained at least 60% or 0.60, no, in decimal. So this is 0.60. This means that the FiO2 level must be maintained or tapered down to 60%. So another form of ventilation is we have the non-invasive. So in non-invasive ventilation mode, it is more that we are not using the artificial airway such as endotracheal tube. So this strategy uses usually the BiPAP mask or interface. So there will be a BiPAP mask interface. So this is an example of a non-invasive, no. So it's more on a pressure drive, no. So the patient is placed or have an harness called the BiPAP mask or the CPAP mask. So it is a strategy using before guidelines in UPPGH, no. So before you intubate patient, there is a trial and error. You tend to try the patient with BiPAP mask or use the NIV mode before going to an invasive mechanical ventilation. So we have also the other mode, the pressure support ventilation. So this type of ventilation mode aids in the weaning process. When we say weaning means that you are testing the patient or placing patient or put the patient, priming the patient, be ready to extubate or wean off from the ventilator. So you are liberating patient from a mechanical ventilator. So ang support mo with a ventilator, no, or a respirator like Hamilton, binuhok mo yung pasyente mo. So when we say in this weaning process, no, so weaning process is you are training or practicing your patient to breathe in his own. So dapat the patient must able to regulate his own. Again, the patient must able to initiate his own spontaneous breath, no? Because in your ventilator, all the breathing, sometimes when you say an assist control mode, the patient is breathing mechanically or assisted breath siya. So hindi siya maganda because all the breath effort of the patient is assisted by the mechanical ventilator. So in the weaning process, you are helping the patient to breathe in his own. So this means that the patient is creating or initiating his own spontaneous breath, own work of breathing, patient own effort of breathing. So with the aid of, pero meron siyang pressure support, no? Pressure support lang, hindi siya assisted like na in every cycle of breath there will be a controlled or preset tidal volume. In these instances, it is only just a support during spontaneous breath of the patient. So from that intubated patient, your goal as a respiratory therapist is to wean off patient or liberate patient from the machine or a respirator. So that's primary goal natin pag sa clinical setup tayo ng pasyente. Dapat as a matter of a short span of time must be liberated or wean off from a mechanical ventilator. So ventilator controls. So we have control mode. So what is a control mode? So the mode, what we call control mode, is we put patient is not able to trigger the ventilator breath. So inspiration is strictly time triggered. So this is part of the patient. You can only put patient in control mode when you paralyze the patient or put patient in a coma. So in this mode, patient, what we call is 100% of the control is triggered by the ventilator. Okay. I'm experiencing some technical problem on my slides, no. So guidelines, no. So that we review the guidelines. So that's the non-invasive or the pressure support ventilation. So we need to proceed now to the ventilator controls. So control mode means that the patient is not able to trigger the ventilator breath. So all the breath will be initiated by the ventilator. So the patient should be heavily sedated or put patient into paralyzed, or we sometimes put patient in heavily sedated or paralytic drugs. So dapat ng pasyente mo nasa coma mode para hindi siya mag-trigger ng breath niya. So the ventilator will be control, the breathing will be 100% controlled by the machine. So it is seldom used in the clinical setting but still appears on the National Board of Respiratory Care exam occasionally, no? So you can only put the patient in a full control mode. Remember, if you sedate or paralyze the patient. So that's the main what you call logic for the control mode. So and then from the control, we have the common, the assist control mode or the AC mode. In this mode, each breath is either patient triggered and time triggered. So pag ang pasyente hindi for its initial critical care cases, if the patient cannot breathe, no, so the initial setting will be the assist control. It means the patient, if cannot trigger, there is a preset parameters or preset cycle of breath, preset tidal volume, and preset FiO2 in order to the patient can be assisted in his breathing. Pag hindi siya naka-trigger, the ventilator will trigger based on the preset tidal frequency or respiratory rate or breath rate. So mostly this coma patient always put on the AC mode. So critical cases or patient first initiated our initial parameters of mode. This is mode, no. One of the parameters is put on the AC mode. So we have the SIMV or the synchronized intermittent mandatory ventilation. So it's another mode, SIMV. So the synchronized intermittent mandatory ventilation mode or SIMV allows the spontaneous breath. To shortcut the definition, 50-50. So 50% will be spontaneous breath or patient effort, and the other 50% will be ventilator initiated. So this is a 50-50 when we say. So this is a winning technique also. Pag nandito na, parang you are also weaning off the patient to a ventilator kasi tinuturuan mo yung patient to breathe in his own, pero 50% lang. So 50% of the breathing will be initiated by the patient synchronously because of the word synchronize, papasok dyan. And then the 50% will be initiated intermittently based on your mandatory or preset settings. So, mandatory, ibig sabihin, may sinet ka na parameters na tutulungan yung pasyente sa pagiging 50-50. So, remember that. So, continuous positive airway pressure or the CPAP. So, this is a preset pressure. So, maintain. So, it's like a pressure support lang siya. So, may preset pressure control ka. It's the last stage or what you call the weaning part of the ventilator. So, pag naka-CPAP mode na yung patient under this mode, it means the patient is unable na to breathe in his own. So, we can hear another parameters like VT. What is VT? So, you just remember Vilma Santos or Ate V. So, the V stands for volume. So, VT stands for tidal volume. So, setting the tidal volume. So, how we can set the first parameter or one of the many parameters, no? So, to start with, in the very basic parameters, we have the tidal volume. So, we determine the delivery of tidal volume to the patient in milliliters or liters. Should be set depende sa body weight, sa condition natin. So, we have guidelines when we say tidal volume. So, meron tayong sinasabi, guidelines for a normal should be 8 to 12, no? By the book. Pero, although 8 to 10 will be the most common in the practice. So, 8 to 10. We will stick to 8 to 10 for a normal lung condition. May use as low as 4 to 6 in cases of patient with ARDS. So that's the magic number, 4 to 6 for patient with ARDS. For patient with COPD, so we tend to use the 8 to 10 mils or 8 to 10 milliliters per kilograms as general adequate tidal volume for COPD, no? Pag ARDS, 4 to 6, pag COPD, 8 to 10. As a rule for other sa ating pinagkasunduan, 8 to 10 for a normal adult lang. So, nagluluko talaga siya, no? So, just wait. I will fix the laptop. Complicated masyado. So, for children, so iba yun, no? So, this is the guidelines for the tidal volume. So, you need to compute that kilograms per milliliters per kilogram. That should be based on a lung condition. So, use the tidal volume as that do not cause overdistension of the alveoli. So, pag bigger, it will damage your alveoli. Yun ang ibig sabihin niya. So, the pressure must be maintained, the alveolar or static pressure or the PIP must be less than 35 centimeters of water. So, the scale is 30 to 35 centimeters of water, but we need to maintain not more than 35. So, the PIP or the peak airway pressure, alveolar pressure must be maintained less than 35. So, for children, we use 5 to 7 mils per kilograms of ideal body weight. So, when we say ideal body weight, we computed in this formula. It is based on males, it is different. Pag sa females, is different also. So, pag males, nag-start siya sa 106. Pag females, it starts with the 105. Try to appreciate the equation for the ideal body weight. Note that the ideal body weight is not the actual weight on the weighing scale of the patient, no? But in this formula, it is based on the British metric system, which is in pounds, no? So the book teaches calculating the ideal body weight in pounds. So that is the formula in conversion of pounds, and then getting it to the tidal volume. So as you notice, 105 for the females and 106. That is very be careful. 106 for males, 105 mas lesser ang computation based on these magic numbers, no, or variables sa isang equation based sa sex, no, or gender. For example, a normal female, so the physician wants your recommendation as a respiratory therapist for the ventilator settings, particularly the tidal volume for this height of 5.3. So you need to compute 5 feet 3 inches into inches. So that's the formula. This refers to the formula. And then for children, always use 5 to 7 mils per kilogram to attain the ideal body weight. So increasing the tidal volume means increases the alveolar ventilation, wherein decreasing the tidal volume decreases the alveolar ventilation. So this is directly proportional to the alveolar ventilation. Remember, your tidal volume, once you increase, there will be a good oxygenation. When you decrease tidal volume, there will be a poor ventilation. So in our case, like for acute respiratory distress syndrome case, for the ARDS, so in case number 1, you need to do the substitution. So according to the statement for ARDS, so 4 to 6 mils per kilogram. So we need to adopt the highest, in this case, the highest range. So use the 6, no? Although 5 ang the ideal or the mean will be the 5 mils, but as a rule, para hindi tayo mahirapan sa pag-check sa examination, it will be standardized. Use the 6 mils, no, to compute. So once you derive the IBW, you need to multiply it. You need to multiply. So you need to multiply. What does it mean? So you need to multiply. Ayan, nakita nyo ang answer. It will be multiply. The VT is 10 ml for this case. Nakita nyo because 10 times 55 kilograms, the 55 is derived from the ideal body weight formula, and 10 ml is based to the normal lung condition, because in your case study is based to a normal lung, so 8 to 10. So in the second ARDS, it's based to 4 to 6, but as the rule, choose the highest range of, like for example, 4 to 6, the 6 will be the multiplier. In the case number 2, the COPD case, or the chronic obstructive with a height of 6.9, you need to convert 6.9 feet into inches and then multiply it by 10. So the highest range for this COPD is 8 to 10 as the guidelines. So 10 will be the multiplier once you derive the ideal body weight. So you add on. So pag this is a female, so the formula will begins to ideal body weight is equals to 105, etc., etc., based on the equation. So be careful with the case. You need to analyze the case study. If the patient is normal, if the patient is ARDS, if the patient is COPD. So that is all about on ventilator management. We derive the ideal body weight in order to predict or compute the tidal volume of your ventilator, and tidal volume as one of the parameters in the ventilator. So we will be seeing on the next topic on more and more appreciation of the different parameters. So we're introducing the first parameter in this lesson, and I hope you decipher the knowledge in management of mechanical ventilation, and then under the predicted tidal volume based on the ideal body weight. Thank you for your time. See you on next lesson.